navigating the spectrum, a comprehensive look at pediatric ocular diseases. So, although we had to start with Mr. Alex, but as the attendance is not up to the mark, so I would like to request Professor Majid Malik Saab first for his talk. He will talk on pediatric cataract surgery, pearls. Thank you, sir.
Thank you very much.
Dr. Chaudhary.
Good morning to everybody.
Only.
And it is not a problem. People take time in coming in the morning session. So shall we start now? Thank you. Good morning to everybody. Let's start the session with pearls and periods of pediatric cataract surgery. So who are the candidates for pediatric cataract surgery? Any lens opacity more than 3 mm, which may be in any part of the lens or associated with nystagmus or squint. Timing, you can correct me. Well, it is an interactive session. Wherever you feel there is a change in the guidelines, otherwise you can correct me. So as per previous guidelines, if the cataract is dense and unilateral, we should operate not later than 4 weeks. If it is dense and bilateral, we can wait up to 6 weeks with only a gap of 1 week between the two eyes to avoid the risk of amblyopia. Now, surgical technique. Phacoincision, very important to make phacoincision in any cataract, particularly in pediatric cataract. And we should, मैं बार बार ये बात करता हूँ कि we should develop habit of teaching our juniors to make incision in a way that it is self-sealing. आज I will be going a bit of away from the guidelines कि मैं suture भी नहीं लगाता वैसे. So it should be 2 or 3 step incision. You may apply 1 then O suture if you need, but sometimes it is not required. We can once we have done incision and we have entered the anterior chamber, after staining the capsule, next is the CCC, capsule rhexis. Always stain with the trypan blue in pediatric cataract, and we should use soft shell technique. I think everybody is aware of what is soft shell technique. We put this dispersive viscoelastic anteriorly and cohesive posteriorly and make a deep anterior chamber so that we safeguard the cornea as well as we have pressure on the lens capsule to have a good uniform CCC, because there is all the chances of extension of CCC, central capsule rhexis, in pediatric cataract is much more than elderly. जितना बच्चा छोटा होगा इतनी ज़्यादा होगा, because capsule is highly elastic and it runs away easily. It gets out of control. And at the same time, we should have other accessories ready at the same time. When we are doing CCC, we should have our capsular scissors, utrata, and all the things should be there with us. Force British cutters, vitrectomy की बार करनी पड़ जाती है ऐसे. There I have seen pediatric cataracts with such a dense capsule and calcified in some children that we have to do anterior capsular rhexis even with a part of British cutter. Aspiration is not difficult generally. We can use phaco tip or bimanual simple cannula if it is soft cataract. But hydrodissection should be done, soft hydrodissection, and that will separate the lens from the capsule. The mandatory thing is posterior capsulorhexis or capsulotomy. If the child is under 5, not only posterior capsulotomy but anterior vitrectomy is mandatory. If we don't do, the anterior vitreous face gets opacified. But up till the age of 8 years, in children between 5 to 8 years, we can go only for posterior capsulotomy without anterior vitrectomy. इसमें अब डिस्कशन है IOL इम्प्लांटेशन. जनरली I don't implant IOL before the age of 18 months. क्यों जी? Is it okay? Because there is quick shift to myopia in the earlier children. 1 year पहले मैंने कुछ किए हैं तो I have to apply piggyback lenses after few years. अब तो वो बड़े हो गए बच्चे. हाँ, एम्ब्लायपी बचाना है आप. Basically purpose is to safeguard the employee because जितनी मैनेजमेंट करें they will not be that careful. Thank you. So biometry rule of 8 minus age, ये स्टैंडर्ड है. वो जितने एज है उससे 8 करते, जनरली इतना हम करते हैं. तो टेक्निक्स ये हैं कि बिफोर 5 years एज कैटरेक्ट एक्सट्रैक्शन, पोस्टीरियर कैप्सुलर एक्सेस, एंटीविट्रेक्टमी एंड IOL इम्प्लांट मैं पहले बात कर चुका हूँ ये. और आफ्टर 5 to 8 में हम सिर्फ कैप्सुलोटमी करते हैं. कैप्सूल PCC हम we can do before IOL implant as well as after implant surgery. If it is after surgery, then we have to use vitreous cutter for posterior capsular access. By planar anterior vitrectomy and lancectomy, I don't do. There are people who do it who are primarily vitreoretinal surgeons. It is easy for them to go for this technique. So this is a traditional anterior approach with anterior capsulotomy, capsular access actually, phaco, and then posterior capsulotomy. So the way I told, we have to make a side port, main incision. Side port should be small. It should not be leaky when we are operating through the main incision. Stain the capsule mandatory. It serves two purposes. It stains the color of the capsule and it makes it a bit stronger than the normal. तो इस जिसमें stain किया होता है, इसमें running off the recess is a bit difficult. It is more stable as compared to unstained. Improve कर, हाँ, elasticity कम कर देता है, strength उसकी बढ़ जाती है, hard कर देता है उसको. Viscoelastic. And preferably we should make habit of using Utrata because it makes a more stable recess. But if you are trained and skilled with this capsulotomy forceps, it's okay. System is okay if one is used to that. The lens cathode is central in the nuclear area of the lens. Peripheral is all clear. We should be very, very gentle, and we can use and add viscoelastic time and again because chamber should be kept deep. Otherwise, chances of stretching and running of the recess is fairly high. Generally, our pediatric patients are under general anesthesia. Patient and patients. This gentleman has to lead maybe 70, 80 years of the life. So we should be very, very careful. If I am operating on an 80 years old man, then there is a lot of difference. Posterior capsulotomy. Just make a nick and one has to be very, very gentle. And some people are very good and well expert in this. Other day, our colleague from Egypt, Yahya, was there. He regularly performed this posterior capsulotomy in everybody up to the age of 20-25. वो एज ए रूटीन करते हैं. वो कहते हैं PCO बनना है, यंग एज में बनता है तो जाता ले करते हैं. So that's now we have posterior capsulotomy, anterior capsular access, and then we can place the lens. बच्चे में वेट बड़ा स्टेबल होता है, नहीं आता बड़ा में तो as the age grows. Anterior vitrectomy to prevent opacification of the anterior vitreous face, it is mandatory under the age of 5 years. 5 to 8 में सिर्फ पोस्टीरियर कैप्सुलोटमी कर दें, that is enough. Or after 8 you should go just like adults, because the child is quite cooperative for GI capsulotomy. Then you should go right now, right? At any age, you should go with that. At any age. In this patient, it was actually a single piece IOL implanted in the bag very easily, because there was no vertex issue and nothing. Then clear the anterior chamber from viscoelastic. That seal the wound, and then इसमें एक suture लगा है. Preferably in younger children, we should have a suture because of elasticity of the cornea. This is another video. It is a bit different. इसमें लेंस पहले डाला गया और पोस्टीरियर कैप्सुलर बाद में की गई है. बाकी प्रोसीजर फर्स्ट स्टेप देखिए ना, फर्स्ट स्टेप इज लाइक दिस, देन सेकंड स्टेप नो वी यूज सी डिंपल साइन एज वी दिस enter the anterior chamber. This dimple means that you are entering vertically and you have made the third step of the incision that will make itself filling. इस baby से बड़ा था. I will not use suture. Side port. बाकी step उस तरह हैं तकरीबन सारे. Another side port for vitrectomy or for safety. Person पास पढ़ नहीं सकती. Again the same process of staining. Clear the stain from the anterior chamber after staining the capsule, and then viscoelastic fill the chamber. Then small nick with the cystotome and then enlarge it with the utrata. But viscous should be very stable, preferably cohesive before capsulotomy. Gentle hydrodissection that will make the life easy from either side. It is a very soft cutter, it will come out easily. You can use Simco as well if the risk that you may not. इसमें कैप्सूल में रेंट आ गया तो कोई बदन कैप्सूल में वैसे भी आपने करनी है. इसलिए you can use this technique. Multipiece IOL implantation in this case. It was slightly elder child. 4 years का बच्चा था ये. Preferably we should use multi-piece IOL because it prevents phimosis and keeps the lens stable in the bag. Now once done and rotated, then do vitrectomy. Central hole in the posterior, you can see this is the hole. Posterior capsulotomy. It can be done before the implant of IOL, and in such this case we can do easily after the implant of the IOL. Both posterior capsulotomy alongside anterior vitrectomy. in this patient of child 4 years age, I didn't do incision because, suture, because for suturing you may have to do another anesthesia, and then for post-operative refraction another anesthesia. So to minimize the anesthetic trauma of the child, preferably if the wound is well sutured. अब देखें इसको, it is well tight wound, sealed wound at the end of surgery, well formed anterior chamber. Next day, and there's no problem, so we can go without suture in such children if the wound is proper, incision is proper. Thank you very much.
If the-
If the wound is properly sealed and properly made, मैंने थोड़ी देर पहले जो बात की थी, there are 3-step wound, and this baby was 4 years old. This child was not 1-2 years old. If the child is 3 to 4 years old, and if you are in the habit of making a corneal incision, which is 2-step at least, 3-step. आपने देखा वीडियो में जो 3rd step था, it was dimple. We go in the corneal substance, and then before decimal we divert our direction posteriorly. So there is a step, that is definite step. That step sealing, if at the end of surgery you have filled the anterior chamber with the BSS, and you see that there is no anesthesia वाला ऊपर नीचे करता है ना, जब बच्चा anesthesia out हो रहा था, you keep observing. अगर नहीं हो रहा तो sealed है तो there is definite that this is not going to leak. But if there we give straight wound as usual, उसमें लीकेज ज़्यादा होगी, उसमें आपने सुजर लगाना है उसमें, या बच्चा बहुत छोटा है फिर भी लगाना है. मैं 2 साल तक लगाता हूँ, 2 साल के बाद मैं नहीं लगा. दे डू भी है, लेकिन मुझे पता है बच्चे. यस 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 श्योर. मैंने 50 का बच्चा बहुत दौड़ता है ना, मेरे अपने ग्रैंड चिल्ड्रन. Yes, they do, but देखा मैंने कि if you make a proper incision, because I followed up कई बच्चों को तो कई साल हो गए आप, but they never had this problem. So नहीं, सेकंड से फिर भी देना पड़ता है, सूचना निकालने के लिए देना पड़ता है. नहीं, your point is valid, but according to guidelines we should make suture. But मैं जो इनसी अपने टेक्निक का उसमें लगाता हूँ, तो I can take chance. Thank you. Any other question? जी मेरा एक्सपीरियंस नहीं, बट इट इज गुड आइडिया टू हैव अ ग्रुप. Okay, thank you very much.
Okay, thank you so much.
One stitch is better than second anesthesia.
Yeah.
So few pearls were, number one, although the wound is small as in phaco in adults, but apply a suture. The second was that as the capsule is very elastic, so you have to be very patient while doing anterior and posterior capsular access. And the third was anterior capsulotomy, posterior capsulotomy, primary posterior capsulotomy and anterior vitrectomy is almost part and parcel of a pediatric cataract. Now I would like to request Mr. Alex Wellen. He is a prestigious pediatric ophthalmologist. He will deliver his talk on ocular genetics on a very important topic. Thank you.
Excellent. Thank you very much. I was asked to talk on an update on genetics of retinitis pigmentosa, and that's really an update on a lot of genetics. So if we go back in time, hold on one second. There we go. If we go back in time to 1857, Donders was the first to give the name retinitis pigmentosa to this disease. It had previously been described. He didn't have fundus photography like this. He actually drew a picture of the retina. And at that point in time, retinitis pigmentosa was thought to be an inflammatory disorder. That's why it's called retinitis, and the pigment was the reactive to the inflammation. But later we learned much more. And in 1980, we had one gene in ophthalmology, retinoblastoma, and it was not till 1990 that the first gene for retinitis pigmentosa was discovered. That was rhodopsin. And as you can see, the red curve, there's been a dramatic increase in the amount of knowledge that we've had over the years. And in fact, this is a paper from my collaborator Ed Stone on 1,000 consecutive families with inherited retinal dystrophies of all types. And you can see we can grasp from this information from around the country that there are some top genes, and by learning what these top genes are, we can then refine our diagnosis. So for example, ABCA4 is the most common gene that causes disease in the retina, causes Stargardt's, it causes retinitis pigmentosa and other diseases. USH2A is the most common cause of Usher syndrome. RPGR, the most common cause of X-linked recessive RP. Rhodopsin, the most common cause of autosomal dominant. So you see, we can begin to learn how to precisely define what the most likely gene is going to be for a given family. And that's the important lesson here. If we phenotype, right? If we go that over and over, we do all the details, then genotype last, our genotyping becomes much more accurate, and we can get much better information, much more real information about a patient. And we're moving away from this generic RP. No longer is a person RP, we can now say you are this disease with this gene, with this mutation, which has great import for the family, as I'll show you. How do we do that? Well, we consider the pattern of RP. For example, if it's nasal spicules more than temporal, that's the most common, is MAC, M-A-K gene. Age, we know there's labor congenital amaurosis genes, congenital RP, so to speak, and the late onset RPs. Systemic associations, is it Usher, is it Bardet-Biedl? We look for the rest of the things in the child. The pace of the disease. A disorder like Batten's disease has a very rapid pace, whereas other disorders have a very slow pace. And of course, family history. Is it autosomal dominant? Is it autosomal recessive? All of these things help us narrow down what our gene hypothesis is. And then we add on to that all of our diagnostic testing, OCT, FAF, Goldman Visual Field, whatever, to help round out our clinical picture before we even consider a gene test. Why do we care, right? Why do we spend time doing this? Well, making a diagnosis is very important for patients and for families. It gives them knowledge. No longer are they the broad RP. We know specifically what you have. It allows them to get support from like-minded group. Now the support groups for RP are no longer RP. There's the CRB1 Foundation and the Usher Coalition. So you can get into the right cubbyhole. You have some feeling of your control over your disease if you know what you have. We can genetic counsel appropriately for whatever the inheritance pattern is. We can identify other family members who may be at risk of having children. And now we can give some idea of the future. Are you going to be driving at the age of 50? What kind of visual aids can you expect? And there's one other reason why this is all important. We're going to take a child now. He's about 10 or 12 years old. He has Leber's congenital amaurosis. His vision is counting fingers or hand motion. We're going to cover one of his eyes, and we're going to ask him to navigate this course, this mobility course. So let's see how he does.
Start.
He's going to go, and as you can see, he just kind of, he doesn't know where to start. He's going to get lost on the course, okay? Just keep your eyes on the left side here. And he's just going to go, and he's just going to wander off, and some guy's going to come and redirect him, and he's going to get back on, and now he's going to walk right off the course because he can't see.
Redirect.
He's hand motion, he's counting fingers.
Start.
Now let's take the same child who has a mutation in the RPE65 gene. Let's give him Luxturna. We're going to give it a subretinal injection of a virus containing the RPE65 gene. And just a few weeks later, we're going to have him get back on the mobility course. The untreated eye is covered. He's using the treated eye. We've rearranged the course so that he can't memorize it. And now we're going to, just a few weeks later, and here he goes. Watch the right side of the stream. It's amazing. This kid can do this course. He steps up over the lump, steps over the barrier there. He does the course perfectly. This is restoring vision to the blind. This is unbelievable that we can do this now. Take a blind kid and make him see with gene therapy. But in order to get there, you have to have the right gene diagnosis. If he has a gene diagnosis other than the RPE65 gene, this doesn't work. How do we do that? We phenotype him. There's a characteristic OCT, there's a characteristic inheritance pattern, there's a characteristic age of onset, there's a characteristic, right? And then we can gene test him to find that gene and then treat him. If we just treat based on a big test, say you do a free panel that's available, or whole genome sequencing, what happens is you get a false genotype rate. These big tests, the bigger the test, the more the error, right? Because if you tested everybody in this room, there'd be errors we all have errors in our genes. They're not causing disease, but how do we sort out it gets very complicated. The more narrow your gene hypothesis is, no longer RP, I think you've got this, the more you can rely on the gene test that finds this little test, right? So the goal has become precision genetic testing and accurate genotyping, because that's going to lead to this kind of treatment. So ocular genetics has changed the way we name diseases. Now that we know that ABCA4 can cause all these things, we're going to change it to ABCA4-opathies, not Stargardt and RP and all these things. How we diagnose. Genotyping is a new way, gene testing, of making a diagnosis, and ultimately how we treat. And it's a role model for all of medicine, right? All of medicine, we're doing this. There's cardiac genetics, neurogenetics, and now there's ocular genetics. And it's made life a little bit more complex because it's harder to do all this, more expensive to do all this. It's created an information explosion, and it's moved out of the realm of just pediatric ophthalmology and created its own field, ocular genetics. But here's the problem. If you look at that curve of all these genes and it keeps growing and growing and growing, what's happened to the membership of the International Society of Genetic Eye Diseases, JET, over all these years? You would expect it to have gone right up the curve, right? More and more ocular geneticists, and this is what it's done. There's a huge gap between the amount of genetic information and the amount of us who are trained to do this. There's only about 70 or 80 ocular geneticists in the world, and all this explosion is going on. In 2018, the FDA approved Luxturna for clinical treatment, the first gene therapy in the human body. Very exciting, right? Very exciting. But is it really? Let's look at this. Tell me, is this a success? It's for one gene. One gene, that's it. It took 20 years to get treatment for one gene. There's maybe 250 eligible people in the United States. Most of them have already been treated. It only works on some patients. Some patients don't have the dramatic improvement that that kid had. Only 17 U.S. centers are allowed to give this treatment. We're one. That means if you are in the United States and you're in a state that does that, you have to travel somewhere else to get it. And it costs $450,000 U.S. per eye. $1 million per patient. Like, that's not going to work. That is not going to work. Of course it's exciting, but here's the problem. There's 150,000 people in the United States alone affected with retinal dystrophies. If they cost $900,000 per year to treat each of those patients, that's $1.35 billion US. It's just not sustainable. And if you look at the rest of the world, and Pakistan is on this, the low-income countries, most of the world cannot afford anything near this, let alone the United States, right? 71% of the world still lives on less than $10 per day. Luxturna is $450,000 an eye. That's $1,233 per day for a year. It doesn't make sense. It's not going to work. What are the barriers to bringing this to places like Pakistan? Is it scientists? No, we got plenty of scientists. We can figure this all out. Is it knowing the pathophysiology of disease? No, we now know the genetics to understand how this disease happens. Is it not having viral vectors? No, it's like spare parts now. We've got all the spare parts we want. We can got the vectors, we got the gene. That's not the obstacle. 75% of the genes, by the way, fit into the virus. This is easy. Is it that there's willing patients? No, there's tons of patients. These patients are dying to have this treatment. The problems are political, financial, the incentive of companies to turn these rare diseases into commodities to make millions of dollars, and sociological. These are the problems of bringing this here. It's not a scientific issue anymore. We've gone beyond the science. We understand the science. So what if we had gene therapy, right? It was open access. Anybody can have it. No patent. We mass produced it. We used accurate, low-cost testing so everybody could get tested. Low-cost treatment. We did it not for profit. No gene left behind. What would you say? You'd say, are you crazy? Right? No industry involvement? No pharmaceutical companies? Do it all in-house? Am I crazy? The answer is no. I work very closely with the University of Iowa. This is Ed Stone in our laboratory there, where we make these viruses ourselves. No pharmaceutical companies, no patent, open access. We can send you the virus in the mail. Our first gene is going to be done this year. It's the MAC gene. We already have enough virus with the MAC gene in the lab to treat everybody in the United States. How much do you think it costs for each one of those viruses, for each patient? Anybody want to take a guess? $50. $50. This can be done, right? How much does it really cost to do the procedure? That is to do the surgery not for profit. Our university is doing all the surgery for this project, and we're doing it not for profit. We can do that $1 million treatment for $20,000. We can do stem cell for $40,000. Dramatically reduces the price. In fact, patients in the third world, patients who low-income companies are going to get it for free. For free. Like, how are we going to do this? We're all philanthropically supported. And philanthropy has driven our entire program. We don't rely on grants. We don't rely on industry. We do it all philanthropically. It allows us to lower the cost. It pays for the testing. All my patients get free genetic testing. Treatment will be free. The whole program development to make this happen is all philanthropically supported. How do we educate places around the world to learn ocular genetics? Go to Orbis. I'm on their medical advisory board. Go to cybersite.org. Everybody in this room should be registered at cybersite.org. There is tons of material out there. Videos, lectures. There's an iGenetics course. We just posted a 122 question called IQ, EYEQ, questions about retinal dystrophies to increase your knowledge. We've got a telemedicine system where we can select patients remotely using telemedicine, help you select who's candidates, help you phenotype your patients, help you learn how to do genetic testing. And we could take care of patients after surgery. But you need patients to lead, you need doctors to lead this effort. And that's where fellowships come in handy, right? And there are fellowships, not many around the world in ocular genetics. We have 2 fully funded positions. If someone from Pakistan wants to come and learn ocular genetics, 2 fully funded positions for a year. What about the treatment? Well, what if I take my retina surgeon, give him a few vials of gene therapy, put them in his pocket, stick them on the Orbis plane, fly him here to Pakistan, let him teach your retinal surgeons how to do the surgery. We'll help you pick the patients beforehand. We'll help you follow the patients afterwards. And then you're on your own. How much does it cost? 0 to you, 0 to your patient. It's just finding the philanthropy to support the mission. You have to have local institution buy-in. I know your patient volumes are huge. It takes dedicated time. My clinic, if I see 12 patients in a day, 15 patients a day, that's huge because it takes so much time to see these patients. But my institution supports that. It allows me to see less patients. Fundraising, there's a lot of rich people in Pakistan. Deep phenotyping, to really do the job to narrow your gene hypothesis, and then precision genetic testing. So no more do we say, you're going to go blind. We don't say that to our patients. Sorry, you got RP, you're going to go blind. Nothing we can do. See you later. When a 12-year-old kid comes to see me with RP today, here's what I tell them. No worries, you're going to be cured. Now I'm seeing patients with congenital hearing loss who get a gene test for the source of their hearing loss. Turns out they have Usher syndrome. They're 6 months old. I tell them, no problem. You're never going to have a vision problem because gene therapy is going to come here. And you're going to be able to afford it. It's going to be accessible. So the whole message around RP has changed to one of hope. Because the reality is, the hope is here. It's becoming realized as a real treatment that's going to be available. We've come a long way since 1857, and we're doing new things, but we have to encourage and grow the field of ocular genetics around the world, and I'm happy to help you do that here. The world is changing. We can do this if we partner together, and we can bring this type of technology, this type of treatment, this type of diagnosis to Pakistan and everywhere around the world, which is our goal. Thank you very much. I want to also just take a moment to thank you for the opportunity to come here. It's been a wonderful visit. You've been very kind and gracious, and I'm very impressed with the quality of the sessions here and the work of the pediatric ophthalmologists. It's really wonderful what you're doing here. Keep up the good work. Very good. Yes. How long will it stay? Yeah, so it's now been 15 years since patients got it, and it's still working. There's no evidence that this is degrading with time. So it shows that once it's in your system, it appears to continue to work in your system. So gene therapy is for patients that still have living photoreceptors that can receive and take up and use a gene. It doesn't cure the disease. It keeps the disease from getting worse. Only living cells will respond. It doesn't bring people from the cemetery back to life, right? Stem cell is for patients who have no living photoreceptors, who need new photoreceptors. What we're doing there is we take a small 3-millimeter punch biopsy of the skin. We culture that in the lab. We turn the fibroblasts into retinal cells. Then the retinal cells, we do gene therapy on the cells and give those cells back to the patient for patients who have no photoreceptors. And that's not available for humans yet. Allogenic, from other people, generic stem cell is. We're doing stem cell treatment specific for your gene to give you your own corrected cells back. That's the way to go if you have all dead photoreceptors.
Trial is going on?
No, there's no clinical trial yet. We're expecting it'll take about 5 more years before that'll be available.
But it is working for the rest of the body.
In the animals, it works.
No, regarding other than eye,
Stem cell?
yes, for the heart, for the other tissues.
There's really no stem cell treatment that is targeted, gene-specific treatment going on in other types of genetic disorders right now. We use stem cells in more generic ways. Use them in your knee. You can get stem cells injected in your knee if you have arthritis. but targeted gene repaired stem cells is not yet elsewhere in the body.
Regarding the stem cell treatment, it is not meant for the genetic disorder. It's also can be used for acquired diseases that happening with the body, like pancreas cells dying down
Yeah,
and the heart cells becoming weak or infarcted.
I'm not as familiar with the other parts of the body yet, but for the eye, that is not yet in clinical trials for gene-specific therapy. There is allogenic gene therapy, stem cell therapy going on in the eye to deliver, for example, rod-derived cone viability factor. And it's amazing how well it's tolerated, but I think gene-specific stem cells going to be a better option.
Okay, Alex, one very small question. It's an excited information that you have delivered regarding open access gene therapy as you people introduced. But what about its FDA approval? Have you got that?
FDA approval?
Yeah.
Yeah, so it's interesting. When Luxturna came out, the FDA approval process was huge, right? Very long. It was the first gene therapy in the body. What we're finding now, and there's now many clinical trials going on for gene therapy, many. They're all pharmaceutical run, but there's many going on. The FDA is getting to a better place where they're coming to realize that putting a gene under the retina is no big deal. We all know how to do that, right? And probably if we're using the same adenovirus, we don't need to have a big approval process if we're just changing the gene inside. So the restrictions are getting narrower and narrower, and it's getting a bit easier and easier. Our MAC gene, which is going to be done this year, is in its final phase. They want us to do a pig study. We're doing that. But it's always getting smaller, smaller. So it's going to get easier as time goes on to get the FDA approval.
Oh, thank you.
It'll still be clinical trial first. It won't go right to treatment.
Of course. If there is any question from Alex.
Yes. Can you use the microphone?
Does the gene therapy in one eye impact on the other eye or on the rest of the body?
That's a great question. So if you do it subretinally in the eye, it doesn't affect the body. It doesn't get outside the eye. When there was gene therapy clinical trial done for Leber hereditary optic neuropathy, it was an intravitreal injection. There was some spread of the virus to the other eye, not to the rest of the body. One of the things we do in these clinical trials is the FDA makes us do urine and blood testing to see if there's any antigen or antibody in the rest of the body, and there has never been from any other trial. So other than that, Leber's intravitreal gene therapy that went to the other eye, there's no effect on the rest of the body.
How is it possible that it reaches the other eye, but it's not rest of the body? How did it reach the other eye?
It's presumably through the optic nerve, the chiasm, and back up the other optic nerve.
Okay.
Yeah.
Thank you.
You know, I think it's important to say that there is a certain popular newspaper level belief that gene therapy is altering us as human beings, and it's messing with Allah, and it's, you know, there's this thought that, you know, God's plan is being altered, but there is no permanent effect on your genome, right? You're still carrying the gene in your eggs and your sperm. It doesn't affect the rest of your body as a human being. It is an eye-specific treatment. And the public has a certain fear of gene therapy, but we're here to reassure them that it's safe. So there's no age limit for gene therapy, but there is a limit in that you have to have living photoreceptors. So with time, that boy, that 12-year-old boy, his photoreceptors will die. One of the great things about RP65 is if you do an OCT, all the photoreceptors are there. They're just not working, right? But with time, he'll get a degenerative retinal disorder, and when he's got atrophy of his macula, atrophy of his photoreceptors, then it won't work. So age is not the issue. It's having living photoreceptors. It is true that the earlier you do it, the more cells you have to respond and to prevent further deterioration. And that's an advantage to early diagnosis. And even for patients where they don't have a treatment yet for their disease, I want to get their gene earlier to put them at the front of the line for when it comes out, we can enroll them in treatment trials. And I'll just tell you an interesting thing so the MAC gene, right? This is very interesting. It happens to be the most common gene for RP in a defined population, Ashkenazi Jews. And they marry very early at 19 to 20. And they have genetic testing through a testing bank. And that allows us to identify people who have this disease and don't even know they have it yet. Don't have a single symptom at 19 or 20 because the onset is usually later. And then we're going to be able to treat them before they ever have a sign of the disease. These kids with Usher syndrome who are identified for their congenital hearing loss, we'll be able to treat them before they ever have a sign of the disease. That's really what the future holds. If you pick them up from their congenital hearing loss, right? They never had any RP yet. It's a little bit of an ethical concern. You're going to be putting a needle under the retina of a 2020 patient as a baby to prevent blindness in the future. That's a little bit, would you do that for your kid? Would you let your kid? That's a big risk, having a subretinal injection for a later future prevention.
And this local injection is not having any effect on the next generation as well.
On the what?
Next generation.
None,
No,
not at all.
not
It's
at all.
confined to your eye.
Not actually changing the actual genotype.
Correct.
Okay, thank you so much,
My pleasure.
Alex.
Thank you.
Okay, go next.
Gene therapy is no more a dream. And the gene therapy and stem cell therapy, they are the future of medicine and great hope for all the mankind. And we are not gods, and we are not interfering with God's problems, and we are just trying to help the patients by different means. So this was an extremely knowledgeing, aspiring, and fascinating talk by Mr. Alex. So thank you so much, Alex. Now I would continue with Dr. Hanif Malik. He will deliver a talk on lensectomy IUL in posterior polar cataract with multi-piece IUL capture video.
Assalamu alaikum, Dr. Hanif, Al-Shifa Trust Eye Hospital. I have divided this video like in 3 parts. First part is the posterior polar suspects. When we are expecting that this is posterior polar cataract, but it turns out to be a normal cataract. So this one is, it gives me impression of posterior polar cataract. After doing the Rexis, I aspirated. I usually don't use phaco. I use this vitrectomy cutter also for aspiration. It was a normal cataract, so I implanted the foldable IUL in the back. I did posterior capsulotomy after that. This one is the second case. It also was a suspect posterior polar cataract, but when I did the aspiration, it was normal. So I put the IUL and this was Rayner acrylic. I did the posterior capsulotomy, and these are the calcified cataracts. Like you see, they give you impression of posterior polar cataract, but actually they are not posterior polar cataracts. The posterior capsule is opacified in these cases. That you see this, but PC is intact, but it is difficult to implant the IUL in these cases. they have intact PC, like this one. So I implanted the IUL, I did the posterior capsulotomy later on. This one is same, but you are under more stress when the private patient says that I want IQ lens in such patients, but you have to do it. So I implanted the IUL in the bag and I did the posterior capsulotomy later on. You see the lens in the bag, there is posterior capsulotomy, it's beautiful rexes, you can see the rexes. I put the foldable IUL in the bag. One thing about these cataracts, the bag is small in these patients. Anterior, posterior, and in the horizontal dimension, they are small. So it's difficult to put the IUL in the bag in these cases. So I removed this posterior capsular opacification with the cutter. It is a bit horrifying, but you can do it. I am behind the IUL and I aspirated this opacity with the cutter. Then I did the posterior capsulotomy. I finished the case. When you are putting the IUL in such cases, the key is, or the tip is, that you just put the one haptic at 6 o'clock and leave the other haptic out. And then you, after putting the lower haptic, you dial the haptic in the back and it is easily rotated. Rest is routine, posterior capsulotomy, anterior vitrectomy. In this case, I was like worried that PC may rupture. So I did the posterior capsulotomy first and then I implanted the IUL. I opened the IUL in the anterior chamber and then with the dialer I put it in the bag. Now these are true posterior polar cataracts in which PC is open. You see. Always be careful when you are coming out of the anterior chamber. Be careful. Put the gel before coming out, because you just see this. I have come out without putting the gel and this is enlarged. But because I had to do the posterior capsulotomy and I put the IUL, so it was not worrying for me, but be careful while you are coming out. So this is multi-piece IUL. I put it in the sulcus and then I captured it, you see, and it is as good as it is in the back. Like Sir Majid, I don't go in the cornea. I go through the scleral tunnel. This one again, second case, I put the IUL in the sulcus and captured the lens. This is again, now this with the, when you see it is posterior polar cataract. Again put the IUL in the sulcus and then captured it. It is as good as it is in the back. And you can see this oval rhexis. Sometimes you come across patients of trauma, and PC is generally compromised in these patients. So be careful when you are doing the lensectomy in these cases. You see PC is open behind the lens. There is PC tear. I did the anterior capsulotomy and anterior vitrectomy. You see there is
listen and feel.
there is scar, which is very typical of traumatic cases. Multi-piece, IL capture, and the rest is okay. Posterior capsular axis, I gave a nick and then I put the gel behind the posterior capsule. Pediatric posterior capsules also are more elastic than the young patients or adult patients. You can stain the posterior capsule with V and blue for better visualization. This is, I don't have any financial interest with these people, but it is now another piece after Alcon, and you put it in the, its haptics are more friendly than Alcon multipiece, and you put it in the bag and then capture. When I did do this Rexis, I used this Canacot to make sure that there is no gel, no vitreous in the anterior or posterior chamber. So you see over here there was a little tags of vitreous, so I cut them with my cutter, and this gives a better look. If you do posterior capsule Rexis and you put the IUL, it gives you a better look of posterior Rexis than this one with cutter. With cutter you can also capture that, but this one is more beautiful. So I think this is last. Capture it, and it is, I captured it even behind the posterior capsule. Thank you very much.
Is anyone here ever had difficulty with vitreous coming forward? The answer has to be yes, because when we mess from the front, vitreous sometimes comes forward in kids. We do all of our posterior capsulotomies from behind. We do put the lens in with the capsule intact, and then we do a pars plana and do the back. And then you don't have to worry about vitreous. I'm just wondering about the practice differences. In a recent survey, about 50% of U.S. doctors do pars plana vitrectomy and capsulotomy. Is that just not something that's caught on here or not practiced here?
So, uh, what I am doing it from the anterior. I am anterior surgeon, anterior. So I don't have any problem with the vitreous that it is coming out. If I have doubt, I stain it with the Canacart and I then remove it. I have done a few from the posterior, this pars plana, but I find it more convenient than pars plana.
It depends upon the training and the things. But the prevailing practice is that we all go from the anterior side. But Dr. Ali Asadi, I've worked with him. You met yesterday. Yeah, he do the pars plana, and there are only a couple of the surgeons who are doing it from the pars plana. Yeah, yeah. I think, yeah, it's cultural different, and I think the training difference, because those who are trained in USA, they are doing the pars plana one. We who are trained in either in the UK or in Australia, we are doing because we have learned from our mentors doing it the same thing.
Okay, for next.
So both the approaches, they do well, I think, but most of the pediatric ophthalmologists here in Pakistan, they prefer limbal approach. Now I would like to proceed further, and I would like to request Dr. Shabana Chaudhary for her talk on see, listen and feel.
Bismillahirrahmanirrahim. Assalamu alaikum. My topic is slightly different. It's just that to stimulate the hearts, feel, see, listen, being a health professional. So just a case of first case, a female baby presented to us at the week, at 33 weeks of gestational age was the history. She presented, she had the gestational age of 29 weeks, and the baby suffered from neonatal sepsis, apnea. Her birth weight was 1,000 grams. Ocular examination showed pupil engorged vessels, and she was diagnosed as a case of AP-ROP. You can see the vessels over here. So we treated the patient as per our SOPs. We gave the anti-VEGF injection, and then there was improvement seen, but we have to augment it with the laser over here. And after all the struggles and all the things we did, this is a note which I received from the baby. Now she is 4 years old and she is school going.
मेरी तरफ से सबको ईद मुबारक.
She sent me the note of thanks and Eid Mubarak in this last Eid. So this is not the story. That's not very common. Happens. What commonly happened is this one. Okay. Dr. Shivana और Dr. Aisha है, हमारी सिस्टर है, सिस्टर फातिमा है, हम लोग सब Dr. Shivana और डॉक्टर आयशा है, हमारी सिस्टर है, इसके फादर हैं। हम लोग साल 3 में जो मार्च से बच्चों को मारने के लिए आज इंशाल्लाह ताला मारना शुरू करेंगे। Listen, what she's saying.
आंखों का हो, कानों का हो, जो भी है, उन्होंने हमें नहीं बताया, इससे हमें अभ्यास करना, वेदना से बोलने लगे, इसकी आंखें इसका वो नहीं है, कि अब इसका कोई मसला हल हो नहीं सकता। हम इतना दुख है, हमारी फैमिली की पहली बच्ची है ये, और हमें 6 साढ़े 6 लाख रुपए वहाँ पे पहले भी कितने अच्छे डॉक्टर होने के बावजूद उन्होंने किसी कुछ नहीं बताया। क्या ये मसला हमारी बच्ची के लिए बन गया?
देखिए ये बात अनफॉर्चुनेटली देखा बहुत तो चाहिए कि वो गाइड करें पेरेंट्स को, उनकी काउंसलिंग करें, आपके बच्चों के इश्यू आप बिल्कुल ऐसा है कि जिनके भी बच्चे पैदा हो रहे हैं, जो भी बच्चे 34 हफ्ते से पहले पैदा होते हैं, 7 माया 8 माया बच्चा जो है या 15 बच्चा तो हमें बताना, वो कहते हैं कि उनकी गलती है तो उन्होंने नहीं बताया थी, लेकिन मैं इस बात पे काम कर रही हूँ, मैं हर लोगों को बता रही हूँ, लेकिन मैं हमारा तो उसमें भी नुकसान हो गया था। This is a story which we have commonly come across. ये a mother who spent more than 600K in a private hospital, and she's complaining that the doctor was not aware, they didn't tell us to go and see the eye doctor, and she came to us with blind eyes, and she's saying that मैं तो अब अवेयरनेस दे रही हूँ, मैं तो लोगों को पकड़ पकड़ के बता रही हूँ कि जाओ अपने बच्चों को जाकर डॉक्टर को दिखाओ, लेकिन हमारा तो नुकसान हो गया ना। So this is just my message. Feel the agony and please do spread the word for the screening of all the RDP babies. Thank you very much.
We need to go for a campaign of awareness for pediatricians, especially these children go for common ailments even. I think from our platform of APOP, we should make a task force for creating awareness, not only for the public, but for the doctors who actually have to be a referral source to the ophthalmologist.
Thank you, sir. This is something that shows the empathy. For my young colleagues, I request, understand the patient, why they are there. They have the different feelings. Just understand them if you want to. Madam, अगर मैं वो over the time हो तो मैं इसको बंद कर। ये just a 1 minute video है। ये complete हो गई बस। मैंने केस दूसरा डालना था, वो डाउनलोड नहीं हो रहा था एक्चुअली। So with that, I'm closing down. Thank you very much. Have a very nice Sunday. Thank you.
Thank you, Dr. Shavana, for sensitizing us on a very important issue.
Thank you, sir. I'll be sharing a few cases in which we'll be discussing that every infant that presents with a large eye or hazy cornea is not a case of a congenital glaucoma. Our first case is of a 7-year-old girl who presented with a complaint of bilateral corneal haze. She was already taking anti-glaucoma therapy for 8 months. On history, the corneal haze was present since birth. It was non-progressive, and there was a complaint of decreased vision. It was not associated with any watering or photophobia. There was a history of cousin marriage, and one of her siblings also has similar complaint. So on examination, there was a diffuse corneal haze. The visual acuity was 660 bilaterally. Nystagmus was present. Corneal diameters were 12 millimeters in both eye. The axial length in the right eye was 23, and that of the left eye was 22.7. The IOP in the right eye was 21, and that of the left eye was 22. And the central corneal thickness in the right eye was 690 micrometer, and that of the left eye was 672. So while examining her and taking her history, we saw that there was 3 things. There's the corneal haze is non-progressive, axial length is normal, and the corneal diameter are normal, which are not indicating towards the congenital glaucoma, whereas there's a slightly raised IOP, and according to us, the raised IOP was due to the increased corneal thickness, and it was not due to the glaucoma. So what we did was we stopped all the medication, all the anti-glaucoma drugs, and asked the patient to visit us on a follow-up and and ask the parents to bring the other child. So on the follow-up, here's the brother, and he had a similar finding, and the IOP was like around the same. It was more or less same. So we stopped all the drugs and sent the children home. So there was so it was a case of corneal dystrophy. Our diagnosis was CHE. So now we have a second case of an 8-month-old baby. He was already a diagnosed case of congenital glaucoma. He was taking anti-glaucoma drugs and referred to us for the IOP measurement. Maybe there was in that hospital eye care was not working or something, so they referred us for just the IOP measurement. So on history, the mother told us that there is a gradual increase in the size of the right eye, and that increase in the size of the right eye associated with the watering. There was also history of corneal haze that settled with the use of anti-glaucoma drugs. There was also a little change in the size of the left eye, but it was lesser as compared to the right eye. So on examination, we saw that the cornea was clear bilaterally. The diameter in the right eye was 13 millimeter, and that of the left eye was 10 millimeters. The IOP eye care in the right eye was 24 millimeter mercury, and that of the left eye was 12 millimeter mercury. The axial length was 24 in the right eye, and in the left eye it was 21.23. Corneal thickness was 556 in the right and 548 in the left eye. So the question raised, all the parameters are pointing towards the glaucoma in the right eye, and the left eye is absolutely normal. So on fundus examination, the cup to disc ratio was 0.6 in, sorry, not millimeters, but 0.6 in the right eye, and in the left eye it was 0.2. So we thought that all the parameters are pointing towards the glaucoma in the right eye, and all the parameters in the left eye are normal. So on repeatedly asking the patient and repeatedly asking the mother about the drug she is taking, she showed multiple drugs, and among all those anti-glaucoma that the child was using, there was another drug that was Tobradex. There was a combination of steroid and antibiotic. The child had an NLD block, there was an epiphora, and she was given Tobradex by someone to use it, and she was continuously using it with all those anti-glaucoma drugs. So we asked her to stop that, and it was a case of a steroid-induced glaucoma and not a congenital glaucoma. Our third case is boy who's 5 years old with a large cornea, and he's using anti-glaucomas on and off, like someone's prescribing them anti-glaucoma, someone's stopping them anti-glaucoma. So, and the corneas were clear. On history, the patient had large cornea since birth. There's no history of corneal haze, and there's no complaint of watering or photophobia. On examination, the corneal dyers were 14 in the right eye, and that of the in the left eye it was also 14. The IOP was 10 and 12 in the right and left eye. The CCT, the central corneal thickness, is 520 and a 523 in the right and left eye. The CT ratio was 0.3 and 0.3. The axial lens were normal. So it was and we stopped all the medication for 2 weeks. On the follow-up, the patient had the IOP of 14 millimeter mercury in the right eye, and the left eye was 12 millimeter mercury. So we stopped all the patient, did retinoscopy, advised the glasses, and sent patient home, as it was a case of megalocornea and not the congenital glaucoma. Thank you.
Dr. Amna, but your first case was not a big eye. So your topic was large eye. The first case was of hazy cornea actually.
Yes, so I said that all the large and hazy corneas are not the cases of congenital glaucoma.
It was not large.
Yeah, it was
So
hazy.
hazy cornea is again, yes, it again is a diagnostic challenge.
Yeah.
But your second case was extremely thought-provoking, and there is always an injudicious use of steroids, especially in NLDBO. So we have to be really careful. Thank you so much for the nice talk. Now I would like to request Dr. Tanveer Chaudhary. He will deliver a talk on role of video information to increase ROP awareness.
Thank you so much, and thank you for adjusting me in this talk. ROP has always been very close to my heart. Mera pointer hai. And every lecture I say, no child should go blind through ROP. No child should go blind through ROP. That should be all our motto. I don't have any disclosures. So I all know that ROP is a major cause of childhood blindness, becoming a major cause of childhood blindness in developing countries, because the diagnostic and the saving rate of premature children is much better, not only in cities but also in areas which are close to cities. That increases the challenge. We are still getting delayed presentations. We are getting stage 5 and 4 and 5, and we have reasonable amount of work still to be done. We need to do more. As I always say, no child should go blind through ROP. We have been through lots of epidemics. There was epidemics of not knowing, epidemic of knowing but not equipped, an epidemic of knowing, having equipment but lack of awareness. I think this is what we all go through right now, awareness. Awareness not only in ophthalmologists, in general public, but also in lots of NIC units. Why we want to increase awareness? Because ROP, when we diagnose at this stage, we can reverse it, and we should not ever reach that stage of white eyes, and we still see them. Because treatment is simple. This is me treating, injecting anti-VEGF in the incubator. And one of my colleagues said, this child cannot be moved to theater. You said you need to give an injection. And I said, I'll move theater to an ICU. Don't worry, but this is that important. Laser can be done if needed, and we have saved lots of eyes through that. We have done a lot of work previously. It may sound like an individual effort, but lots of people are doing it, saving eyes. We have done work on incidents, of ROP in tertiary care unit. Sorry, I'm trying to be quick here because you're short of time. Study was done on awareness within the city of Karachi, and we went to different hospitals and found out that the knowledge of ROP was very basic, and some did not have any protocol of reference. In fact, we got some aggressive responses that you people come from big hospitals and trying to teach us, although we don't, or most of our patients don't even afford your. So this was completely taken wrong way, our visit there. There was a study published in British Journal of Ophthalmology, changing the criteria, and recently I did single dose ranibizumab in intravitreal injection, reversing stage 3. Present situation, because on one hand, the reduction in the risk of diagnosis and treatment values are more, the NICU are better equipped, we are saving more children. On the other hand, lack of awareness is increasing the number of blind children. As somebody mentioned here, one child was advised to have our social, cultural beliefs. One child was told to have need of injection. The parents did not comply. The parents did disappear. They went to these soul healers and they said, well, change the name and just pray and everything will be fine. The child went blind. And then on the base of that, when the next child, their family born premature, they actually were right at the door and saying, well, doctor, do whatever is needed. We don't want another child to go blind. So in video presentation, we have actually made a 3-minute video, informative video, and this is not for gynecologists or pediatrics, but it is for NICU. We have list of 12 or 15 hospitals in the city where we are getting all these children of advanced stages. People are not being asked to see the doctor with strongly enough. They said, doctor ko dikha dena, go and see the doctor, go eye check kara lena. No, you have to put fear in their mind. You have to put fear in their mind that this child is going to go blind if you don't go. This is not happening. On the contrary, I did give a lecture of attitude of doctors. We are not showing empathy. We are not showing sympathy. It's not the child who's a patient. Child is a patient, but it's not the child who's a patient. In this situation, it's the parents who are the patient. You need to sit with them. You need to talk to them. You need to give them sort of information at every visit. What you're planning? What are you doing? Because they need to know. And I've seen many confused parents coming from different hospitals and saying, doctor does not talk to us. Doctor actually shout at us. This is not the way it should be. So we have decided, we have visited few hospitals yet. I am going to visit all the hospitals, giving them awareness, and then go back to those hospitals 3 to 6 months later and see whether we have improved the awareness. But this is just one city. And I want everyone to do, as Dr. Saab said, this has to be a campaign, this has to be a larger scale movement and raising awareness. And if we don't do that, we'll continue to see children who are being ignored, either the parents or the doctors or the culture or whatever. Unless we change this, we are never going to overcome this epidemic of ROP. So multi-center should participate, train our doctors, have more red cams. So pictures are important and present it to the doctors. Way forward, as I said, one of my patients came from, she saw my video and she came from a remote area or remoter area of Sindh. And she said, "Humne aapki video dekhi thi, that's why we are here." Nobody referred her. This is not going to happen, that we have lots of incubators, we have a nice NICU, we are saving the children, but we don't know about the basics that we are going to save this child as a whole and not just the child who's breathing but can't see. We can use a diabetic retinopathy module that remote areas can have RETCAM. There are technicians who are taking pictures, sending it to us, and then we can decide whether this child needs any help or not. So identify in time, treat in time. We should not ever see this picture, and this is what our goal should be. We should do everything possible for these children to be able to see this beautiful world. The picture I took in Singapore, we take it for granted, but we should pass it on to others as well. Thank you so much.
Thank you so much, Tanveer. Actually, this is the need of the time, because by doing it, we are actually saving the sight of a person for about averagely 60 years. That's why we need to go ahead, and your suggestions are well taken. And inshallah, in next meeting, our association will try to find out some ways to go for it, inshallah. With this, we come to the end of this session, and I hope everyone took some messages. So, I would like that all of you come here for a photograph, please.